Hi, everyone, and welcome to the Rehab Podiatrist podcast with me, Alex Murray. I'm a podiatrist and strength and conditioning coach based in Canberra, Australia. And I'm really excited to talk on this episode about injury prevention. It's a topic that comes up quite a lot with patients. They come in, they want to prevent injuries from happening again. They're sore now, or they're coming in because they've had an injury and they're like, I don't want that to happen again. It was horrendous. But when we have a look at the literature, it's really not that simple. Where we see biomechanics not being a risk factor, so we don't address them. We see training errors. Everyone says they're a big risk factor, but we find no consistent results when changing them. We've got acute chronic workload ratios. We've got a whole bunch of these other metrics, and it doesn't seem to be there to be a silver bullet. Footwear very consistently doesn't show that it prevents injuries. We have orthotics or custom foot orthotics, which can help in very specific populations, but really, again, doesn't have a wider applicability. We hear about things like psychological readiness, and we've got people like Tim Gabbett who are out there saying, we should be pushing our patients to do more and more, while we've got traditional messaging saying, well, if they do too much, that's the training error that creates the injury. So it's a little bit of a confusing space to be in if you're trying to look in and get a good understanding. So what I wanted to do is get someone on to talk about it, try and make sense of this mess. And who I've found is a good friend, Travis Pollen, or I should say Dr. Travis Pollen, who's a assistant professor in exercise science at Jefferson University. And obviously he would do a much better job at introducing himself. So hello, Travis. Thanks for coming on.
Hello, Alex. Thank you for having me, and awesome work on that intro. I think you really encapsulated the problem, and hopefully I can shed some light.
Hopefully, yeah. Well, before we obviously dive in, do you want to talk a bit more about yourself, your qualifications, your experience?
Sure. So, as you mentioned, I'm an assistant professor in exercise science at Thomas Jefferson University. I've been teaching exercise science for a couple of years now. Prior to that, I did my PhD in Rehabilitation Sciences, where my research focused on risk factors for injury in competitive swimmers. So my bread and butter is injury prevention. It's what it's what I like to do. Reading about it, chatting about it. So I think that we really connected on this through a masterclass that I created for Physio Network on injury prevention, where I kind of did like a pretty deep dive over a couple of hour presentation on how injuries happen and how we can prevent them. So that's kind of the area of research. And as you mentioned, some of the risk factors, biomechanics, training load, exercise as prevention. I've taken a pretty deep dive into these things, and so while I'm not a podiatrist myself, my hands-on background is as a personal trainer. I feel like I have a good BS detection meter for things that seem like we want them to work, but from a research standpoint, like we just find that the findings are very conflicting, or maybe things that we think work don't work at all when you actually drill down into it with the research.
Yeah, well, that's exactly why I got you on the bullshit meter. We were talking before. The whole podcast is just going to be just me just saying things to you, and then you just saying bullshit or not bullshit.
That's perfect. It's all going to be bullshit then.
Just like magnetic insults. And you're like, actually, what I think's probably a useful place to start, having watched your masterclass, sort of gone through sort of the deeper dive, is what can you provide sort of an update really on what we're talking about? We're talking about injury prevention and the process of trying to prevent it, because we often think that it's a case of, well, you have an injury, like someone's twisted their ankle, someone's had they're starting to get an overuse injury in a tendon, and you sort of think, how do I take away the negative thing from that? Mm-hmm. It's not from going through some of your work. It's not that simple. Can you talk more to that?
Yeah. So I think the the simplest explanation when we get injured is, well, the injury was because of this one thing. And it's like a nice, cute story that we can tell ourselves. And then we can say, well, if we just fix that one thing, then we won't get injured again. And what we have found over maybe the last 30 years is that it's not that simple. And every like 10 years, I feel like it gets more complicated, but it's getting more accurate, I think. So if you rewind like 20, 25 years, there was this model of injury that came out, and it kind of showed this linear pathway where like you start with the person who has some predisposing factors. So that could be things like they're older, maybe for a specific injury, it's related to their sex, they've had previous injuries, they have low skill at the sport or activity that they're doing. So all of these factors can predispose them to injury. But if they just sat on the couch, they wouldn't get injured, right? It's the exposure to playing the sport or doing the activity that actually puts them in a position where they're susceptible to getting injured. And then when they're playing the sport, they get injured because there's some inciting event that happens where they're biomechanically in a weird position, and their opponent is doing something funky that they're reacting to, and pop goes the Achilles. So, but the way, like, that was a helpful starting point for us to say, oh, it's not just because they are a woman that they tore their ACL, because, women tear their ACL more than men. It's all of these factors. It's this laundry list of things that can predispose them and then expose them in their environment to the potentially inciting event occurring. So that was helpful, but then what we realized was it's not just like you start at the beginning, you're predisposed, you then exposed, and then you get injured. Because every time you engage in the sport or activity again, that whole risk profile at the beginning changes. So as you gain more fitness, or as you repeatedly expose yourself to the activity, you gain more fitness, which in turn modifies your risk factors. As you maybe get injured, and then that changes your risk factors. So the idea is that the person is not this like static snapshot where they come to our office, we measure them once, and that's their risk. We can create this profile, and it's this snapshot in time. But that's all it is, because it doesn't account for the fact that the person is constantly changing. So what we realized was, okay, well, in our conception of injuries, we need to better account for how this person is constantly changing over time as a result of the repeated exposure to participation. So they keep playing the sport, they keep not getting injured, or maybe they do get injured, and then that feeds back into their risk profile. So that was about 15 years ago that kind of thought process emerged, and that was very helpful. But then what we realized about 5 or so years ago was like, it's not that simple again. Because what that model sort of showed was like, it's this, you just add everything up. You add up all of the risk factors, and then the injury happens when the risk factors exceed the sum. Pop goes the Achilles. But what we realized was it's not that like this thing begets this thing begets this thing, but rather that you have to put kind of all of those risk factors in a blender and shake them up. Like that's what's happening. And everything is affecting everything else. So they call that dynamic systems. They call it complex systems. It's basically just this idea of, instead of calling them risk factors, they call them now a web of determinants that are bidirectionally interacting with each other all the time. And not just looking at like the left to right linear causal analysis, but more so this idea of like looking for patterns. So the injury isn't just like a this plus this equals an injury. It's more like you are looking for, it's more like this complex emergent phenomenon that happens when all of these web of determinant factors interact. And so maybe an example that I would give would be, let's say that a person has had a previous injury, which has then caused their range of motion to be reduced and their strength to be reduced, which then they are exposed to a high training load, higher than they're used to, because they have a very demanding sport coach. And it's all of those things that interact together that then contribute to the injury. So it's not just, well, you had a previous injury, therefore you're going to have a new one. Like, yeah, when you do a study, you can look at a risk factor analysis, single factor, and say a previous injury increases your risk. But it's really this pattern of trying to understand multiple factors that then further explain the injury. So you can't just say, well, I had a previous injury, so I'm doomed. It's like, well, what was your rehab like? And how's your range of motion? How's your strength? What's your training load? What's the coaching like? Trying to consider all of those things and many more factors that we can get into when you're trying to understand why an injury happened and then how you can prevent a second one.
We sort of just went on a small roller coaster, because it's just like, oh yeah, like great, we're on the, and then you're like, not that simple. And you're like, okay, next one, not that simple. There's just a lot of growth, and I'm sure as well in the next 5-10 years we'll find that it's not as simple as we think it is now.
Yeah, it was funny for me, like discovering these models as I went through my PhD, because I think I found like the 2007 one first, and then I was like, great, this is awesome, this is what I'm going to base my research on. And then like a year before I started my study, I found the dynamic systems, complex systems one, and I'm like, well, shoot, my single factor risk analysis isn't really going to account for this complex web of determinants, but also I don't have enough people in my study to do the analysis right. So therefore I have to do the simpler one. So, the evolution happened sort of before my own eyes as these papers were coming out while I was in the throes of trying to conduct this study.
Yeah.
Only to find that, well, I have 37 people. I really needed like 800 people to do this study well. So I'm going to publish it in, the 4th journal that I submit it to, and that'll be that.
It's interesting because, yeah, you sort of get like hamstrung in a way because the more complex the study needs to be, the more difficult it is. But it's interesting what you're talking about. When what I'm sort of pulling out is that we're no longer looking at things static. It's looking at them as living, adaptable organisms, and it's sort of focusing on how they adapt to the demands. And it's not so much, you said, sort of, it's not so much about things adding together, and sort of we talked about at the start, the premise is always, how do we find something and take it away? What you're sort of talking about there is that we're almost in ways adding things that are positive. So adding rehab, adding strengthening protocols, adding things that are going to help enhance their range of motion back again. And then it's comparing them to what's being also demanded of them as well. And so taking away, you can also look at taking away, but then there's also that factor of adapting. So you might say, well, we don't actually have to overall take things away, but we might take something away on a certain day and let that living sort of person actually rest and recover and reduce their fatigue.
Right. And I like to think about it as more of like a temporary modification. So, when you say, well, they're injured, so, and they got injured because we think because they were wearing this shoe wear. Well, sure, we could switch their footwear in the short term, but it doesn't mean that the shoes that they were wearing before were bad and wrong and that they should never wear those again. It's like, well, yeah, if they're causing pain in this moment, let's try something different. But it's not like that's bad and we should never put them in that shoe again. It's like, we're not going to put them in that shoe. We're going to put them in a different shoe right now, which will hopefully modify their symptoms and maybe allow them to continue doing some aspect of what they were doing before, maybe not all of it, and just kind of trying to play with all of these things at once and hopefully build them back up to where they were before or better.
It's interesting. I guess the example the analogy I always think about is sort of related to cooking. And I know not everyone cooks, so it might not sort of always land, but I like what you said about the blender, where we're sort of throwing everything together and then blending it up. And I think about what you're sort of talking about is, well, if you're baking a savory pancake or a crepe and you start throwing in ham and cheese and things and you blend it up, and you put it in, it quite works. If you're looking for a sweeter pancake, you're obviously going to use more sugar, and you're sort of looking at what you need specifically for that task. You're looking at what ingredients you have available, and you're sort of going, well, nothing's really positive or negative. It's just about what this situation needs and would benefit from, but also acknowledging the fact that when we throw that in, it interacts with everything else. So we throw it in. It's not a case of, well, okay, this is just an additive. Well, we think about, if we've ever seen every American cooking viral clip, or those ones in America where it was like the turducken, the guy, and they just kept adding like Jack Daniel's sauce and bacon, and like everything gets better with bacon. We just kept adding more and more bacon, and there comes a point where then that's obviously not just wholly positive. Bacon by itself is seen as something quite positive. In the same way, we can think about, you're like, okay, great, calf raises or a specific strengthening protocol, or, there's a lot of these things that would seem great in isolation. But as you've sort of highlighted, if we're putting it on someone who is already overworked by their coach, that could actually be a net negative.
Right. And that's a really tricky thing, because we have reason to believe, good reason, that exercise is helpful for injury prevention and rehab. But it's like, well, we have to factor in, like, let's take injury prevention, healthy athletes. They're doing a bunch of training already. If we just add on a bunch of Nordics to what they're doing, they're going to be very sore. That could impact their practice, their performance, but it could also fatigue them to the point where it becomes unsafe to practice after that. So then you have to look at it and say, well, what effect is this going to have? Is there something that we can do differently? Can we reduce the number of Nordics that we're asking them to do? Can we progress them more slowly? Can we put them at the end of practice instead of at the beginning? So after they've done their sprinting, after they've done their high-speed running, where it might be risky to pre-fatigue them, and then what effect does that have when we change the order of this on the preventive effect?
So it's a lot more difficult, a lot more individual, but we can start to understand why then the studies are really always not super helpful, and they're kind of confusing, because they're looking at the single risk factors, and they're going in and they're just, here's the one thing we're going to give them, and what do you know, some people reduce their injury risk, some people don't. I guess it's not helpful.
Right. Yeah, and that's the challenging thing, because we want to know what's going to work for the person in front of us, and the research is based on groups, and then it's like, well, why don't we just look at, I was looking into this yesterday, why don't we just look at responder analyses? So like try to find the subset of characteristics that predispose someone to experiencing a beneficial effect of the intervention. And it's like, well, that's really hard to do from a research standpoint, because it's hard to dichotomize somebody as a responder or not. And, the more factors that you look at, the easier it is to find something that you think is the reason why that they responded well. And so it's tricky to interpret, for sure. And also, when you do the research has to be done in a well-controlled setting, right? So you only want to look at a couple things at a time. You want to have a lot of control over the situation, but that's not how the real world is. So we have this challenge where we have something that works in a research study, and it sort of stops there from a research standpoint. It doesn't get tried again in a more pragmatic or real world setting. So then when we try to adopt it, we're not able to recreate those very rigid the framework that occurred inside the study, and then it fails. And it's like, well, is that our fault or the researcher's fault? I guess it's everybody's fault. There's a gap in the implementation of getting it from these rigid conditions to working in the real world with, people have different expertise when they're going to do the intervention. The athletes themselves have different motivations. There's different compliance, perhaps. There's different resources. There's different time. So it's tough. It's really hard to say, well, this worked in the research. This is the program. This is the intervention that I'm going to use with this person in front of me. And you might have reason to believe that it's going to work, but you really have to look at all those things. Is the person in front of me very similar to the people in the study that I'm basing this off of? And if not, and maybe there's no research that you can find, and you have to extrapolate that out to the person in front of you. Like, well, I think that even though this person's different, they're similar enough that we can apply the findings. But it might not always be the case, and there might not be research available, and you might have to take a leap.
Well, I guess that's an interesting question for you in terms of the implementation, because I guess where we sort of end up with what we see online is people sort of go, oh, there is no evidence in this space, so I'm just gonna make it up and see what works for my patient and run with that. If we've got some of these studies and we've got sort of conflicting results on these studies about training and what we do, is there any, obviously being much more familiar with the research, what would be a guide to trying to take these results and implementing them? Because it's sounding like really what we're doing is it's understanding the individual and trying to get them best prepared for the sport without overloading them. So it seems like there's a huge amount that we have to do with the patient.
Yeah. So like the question of, well, how can we apply these findings to the patient in front of us? I think it goes to, well, can we find evidence that it works in a similar group of people, and can we set up the environment so that it's similar to what they did in the research study as best we can, or acknowledge that, hey, we're realizing that we're moving the Nordics from before practice like they were in the research study to after the practice, and being mindful that if you don't apply it in the same way that it was done, then you should maybe be mindful that you might not get the same results.
I guess is there benefit? Well, I guess this is sort of where we look to institutions and teams and people that have implemented specific approaches, because what they're doing is they're doing a real life implementation study realistically. Right. They're looking at the research and going, okay, these people did Nordics or a strength program before training, where that doesn't work for us because I think that's going to fatigue people with our sort of training, so we're going to do it afterwards. We're going to monitor our athletes. We're going to see what happens. Sort of a focus on understanding the research, and then understanding you're adapting it, and then testing and trialing it. I guess that sort of, to me, seems the most intuitive. Is that sort of what if, knowing the research, is that what you would be doing as well, looking at going?
Yeah, and it's tricky though. If you have a team, then you can actually do that. And well, you have a team and you have statistical prowess. You can keep track of that. Be careful what you're changing, and see what effect that has with serial monitoring and measurement. So for example, let's say that you have a hamstring injury problem in your team, and you want to incorporate Nordics into the training program. Well, if you think that the reason that Nordics are effective is because they increase eccentric hamstring strength, and like maybe that is the reason, or maybe that's not, or maybe that's part. Like, I think it's actually more complicated than that, which I don't even understand. But there's fascicle length, but tangent. So if you believe that, well, the protective effect is through increased eccentric hamstring strength, well, you can do the intervention and then measure the player's eccentric hamstring strength before, a couple weeks later, a couple weeks after that, and see if the intervention is having the effect that you want. And then that can be a proxy for, okay, well, I'm not going to know about the injury numbers until the end of the season, but at least I can say that my players' hamstrings are getting stronger eccentrically, and that was the effect that I wanted to have. And by doing it after practice instead of before, my strength gains seem to be similar to when I did it before, or what I'm seeing in the research of the strength gains that people are having from this intervention. So the timing doesn't matter. Or maybe I can find research that has looked at this, the timing of the intervention before or after practice. So all of those things can be helpful, but you need numbers. So if you're one rehab podiatrist with, a n equals 1 or just like a case series, it becomes harder to say, like, from a very objective standpoint, which is why, where you get practitioners saying, well, this is what I do and this is what works, but it's such a biased, it's like, that's not, they think I'm evidence-based, I'm keeping track of this, but it's not to the quality of what you would do, obviously, in a research study. And we don't even realize that we are biased, but it's hard.
I guess it also speaks to the fact that when we talked about there being so many influences on injury, how many people have you treated with a protocol or gotten them stronger, and then they've just incidentally not had an injury again?
Right. So then you take your post hoc fallacy and you go, well, I got them stronger and they didn't get injured again, therefore it must have been this strength adaptation, like it must have been the calf raises. And it's like, there were so many factors that changed when this person got injured and came to you that you can't say for sure. You can say for sure it was all of the things, but you can't say for sure it was any one of the things. So that's where, like, this more comprehensive approach has to be considered of, all right, what all did we change? Well, we changed, we think we changed their strength. Did we actually measure that? They did calf raises. We think that means that they got stronger. Maybe they did or they didn't. Maybe they did calf raises and their confidence in relation to moving their ankle in that motion got better, and that was what contributed to them not getting injured again. Or maybe the confidence that they built through the therapeutic alliance with the practitioner of just building up more confidence in movement, and the education that they received, like it could have been all of those things. So that's where it lends itself to the idea of, well, let's do all of these things, right? Let's get them stronger. Let's get them more mobile if they need that. Let's increase their confidence and psychological readiness. Let's monitor their training, not just give them an orthotic and send them on their way.
Yeah, and I think you said right at the end there exactly what I was thinking. Where it's if we're looking at preventing injury as individual practitioners, when someone comes in and says, hey, how do I stop this from happening again? It's not so much like resting on one thing. It's looking at them as a whole unit and going, what are all of these areas that we can possibly make a change? And say, okay, we can optimize your training load. Those shoes are old, change them. You're getting pain when you're doing this. Let's stop doing that and add something else. We think we can build up your strength. So let's monitor that and let's build the strength. And we're sort of just trying to hit on all of these individual points and just being almost in a way comfortable with not having an answer and going, well, this is the one thing, or this is actually going to have the result. I mean, we've been beaten over the head with this for ages. The whole injury reduction nomenclature sort of push of we're not preventing injuries, we're reducing the chances. I guess it's sort of just getting comfortable with that approach of we're not going to have the answer, but we can do all of these things that are going to best prepare. And I guess the other side of it is the fact that if you're playing a sport and we're just watching the World Cup at the moment, you're seeing all these slide tackles happen, and you're seeing people getting hit and kicked and tripping and falling, and it can just bad luck can happen as well, and a risk can come back. So in a way, it is. I can see what people are saying. We're saying injury reduction because we're not going to prevent all injuries. But it's sort of getting settled and comfortable with that idea, and in a way as well, getting our patients settled and comfortable with that idea.
Right, because they might come to you and maybe they've worked with another practitioner before who gave them a very simple answer and a very simple intervention, and maybe that worked for them, and maybe that's what they're looking for from you. And so you telling them what you just told me, like that might not resonate with them as well. Like they're saying, I want to prevent this injury from happening again, and you saying, well, we can reduce your risk, but I can't promise you that it won't happen again. I can say that in my experience, it seems like when I've worked with people before, we're able to reduce the frequency of recurrence, and we're able to maybe reduce the intensity of a repeat episode, but it can happen again. Here are the many things that we can do, as you mentioned, monitoring training load, getting stronger, increasing psychological readiness, and the list goes on. And hopefully they will be receptive to that. I mean, what's your experience? I'm sure you've encountered these people before, right? Who want this very simple explanation, and then I imagine you have to gradually, if they come to you with that frame of mind, you have to gradually introduce. You can't just open up the fire hose at them and change their worldview in one encounter, but trying to slip in that education, and try to help them come to terms with the idea that it's not going to be a simple fix and there's no guarantees.
Yeah, I guess it depends on the individual. I find. I mean, this is just with anything when I find I'm trying to talk to people about something new. So much of it is drawing upon their previous experience. So like if they've done this, they've changed one thing, but they've very clearly also told me that they've changed 5 or 6 other things in the course. They've changed teams, they've moved competitions, they've changed the ground, they've changed their boots. They sort of went, oh, okay, and you can sort of draw in all of these other aspects. They changed position, they stopped, doing heavy tackles because they've changed the level of the competition over time. Like I can draw in all those factors and say, well, if we're thinking about, you overloading your Achilles or twisting your ankle, well, you're not getting as fatigued now. You're not putting yourself in a position where you're going to get injured. And sometimes that starts to, because it's drawing upon their experience, sometimes that kind of starts to click. Sometimes it's about, them having new experiences. So sometimes it's about sort of going in and saying, well, what if we, maybe looking at it from a more positive perspective and saying, not going, oh, we can't prevent your injury, but actually there's more than one thing that we can do to help. And as we start to sort of do more and more and more, they start to open up and go, okay, I'm not looking for one thing, I'm looking for many things that can help. And we sort of talk about, why an injury, occurs, an ankle sprain, you're landing funny. Okay, so, if we're stronger, you are, you're going to be in that position. You're potentially going to be more able to recover from it. If you're fitter and you're pacing yourself well, you're not going to be as fatigued. If you're not making it like this insane tackle in like the last 5 minutes where everyone just absolutely rooted from playing a full game, you're less likely to then have someone land on top of you. We can sort of talk through all those things, and then sometimes it sort of works then backwards to then say, well, this is also why we can't predict, we can't prevent injury, because we can't also then stop the other person from doing that insane tackle at in the last 5 minutes. We can't always completely control the fact that there's a pothole in the ground that's going to then make you twist your ankle beyond a point where where your body's incapable of recovering from that. So that's sort of where I found to be successful, is drawing upon their experiences and either having to draw upon experiences they've had or giving them new ones to then be able to reflect on. And sometimes as well, it's asking questions of like, how does an injury occur? Or like, if we think about, ankle sprain is always an easy one because it's literally they're twisting their ankle. Overuse injuries are harder, but sometimes exploring and asking questions of how they think injuries occur, and we can start to get the way that they're thinking is what is sort of my experience, and then we can start to explore some of those points. And sometimes when you're asking more questions of them and getting understanding of what they know, I've always found it points kind of jump out you a little bit more. And if you're not finding those points, you go, okay, like you move on. You know not to press. Sometimes it's more therapeutic for us to sort of say our spiel and then be like, I'm done.
Right.
I've said my piece.
I gave you the golden nugget. Now, you have it and you can take it or leave it. It's like, well, that's probably not going to work. But like you said, if you can ask them questions to come upon an understanding on their own, relate it to what they already understand of, I see why the injury happened because, or I see that injuries are not totally preventable because of sometimes it's a fluky thing. We can't control the other person's behavior. Sometimes there's a risk that needs to be taken in the last minute of the game, and recognizing that. And then they can say, okay, I see what you're saying, that we're not going to be able to prevent all of these injuries, but what can you do to help me reduce my risk?
So sort of switch tracks a little bit here. When we're talking about injury prevention, so we're talking quite globally about all of the risk factors and how everything sort of works together. It's not that simple. We have to look at the individual. But also when we're looking at preventing different types of injury, I remember you were talking about primary injuries, secondary injuries, tertiary injuries, sort of narrowing down on what we're doing. Can you speak a bit more about that?
Yeah, so this was like a really helpful categorization of things for me when I stumbled upon it, and the way that I might describe it now, like different people have different ways of precisely defining it, but the way that I talk about it is that primary prevention is the prevention of the first injury. So the person is not injured and we're trying to prevent injury from happening in the first place. Secondary prevention then is identifying people who are just at the beginning stages of an injury. So I think in some countries they call those niggles, but basically it's like something that, unless we're going and looking for it, it would be subclinical. Like it might fly under our radar, but it's something where if we can identify it, then we can prevent it from worsening. So that prevention of worsening is secondary injury prevention. It's already happened a little bit, and now we're identifying it early on in the process before it snowballs into something big. And then tertiary prevention is the injury has happened. It's a full-blown injury, but now we are trying to prevent the injury from happening again. So that's re-injury prevention. And the first step is, well, let's rehabilitate them. Let's return them. Let's go through the process of returning them back to participation, sport, performance, that continuum. And then from there, let's try to prevent it from happening again. Prevent in air quotes, because as we've talked about, prevention is the colloquial term that we use for it, but it's really about reducing or mitigating or managing or controlling risk. And so for most, if you're working as a clinician, you're most of the time seeing people who are already injured, and then trying to engage in that tertiary side of re-injury prevention.
Because I think when you I think that's a good update, because I guess, everyone does explain it a little bit differently. But I like the way that sort of it's broken down a bit more, because sometimes people look at secondary as being the injury has already happened, having that sort of secondary step, and tertiary having that step in between of niggles and then re-injury prevention is quite helpful. The first thing that jumps out to me there though immediately is how we do our research, because it seems like a lot of research is focused on primary injury prevention. So trying to find those individuals that, or trying to essentially prevent all injuries from happening, which seems like a noble goal. But that sort of seems like where we don't find a lot of results. But then when we're looking at secondary and tertiary injury prevention, it seems like that's already something that we can hone in a lot more on, because you have someone who has an injury, so we already know they're a subset of a population. And then there are also people as well that have something that can be actively much more managed. So we're seeing someone with a niggle, you can sort of go, okay, what do we do once a niggle occurs? We could have a much more of an environment where we can go, okay, we need to make sure we drop their training load for a period of time, or we avoid this type of irritating load. We then monitor as we go up. We check for strength deficits. Tertiary is the same. You said at the start, okay, someone's injured, reduced range of motion, reduced strength, reduced confidence in their movement, and then you put them back under a coach that's going to just slam them. We're going to get injured. It seems like that now that we've got that sort of ability to separate people into different groups, it sort of makes a bit more sense where we could intervene a bit more.
Right. So yeah, and I think that the big thing there, like you said, is the monitoring. So we can, let's see where we're at. Well, ideally, in the perfect world, before the first injury, you have a rich data set on this person of their side to side strength, mobility, coordination, flexibility, all the things, so that when they get injured, then you can say, well, here's where they're at the time of injury. Now I want to make sure that I get them back to where they were when they were uninjured, or even better, depending on whatever it was that happened. But most of the time we don't have that pre-injury data, and so we're relying on side-to-side discrepancies and trying to even those things out, which are notoriously not that helpful, because when you get injured and sit on your butt for a month, then the leg that's supposed to be the gold standard deconditions, and you're just measuring the injured side against the deconditioned side, and you say, well, we have a limb symmetry index of 90%, therefore they're ready to go, and it's like, but they're weak on both sides now. So then you have to compare to some age and sex based norm, or maybe you have a data set, best case scenario, you have a data set maybe from your team that you can say, well, this is what people body weight similar look like. But these are hard things to do without that baseline data.
So we're operating generally as clinicians without a lot of this data. Like, people come in unless they're part of quite an established team. I can't think of many sports in Australia that are not at a pro level that will have that data.
Right.
Because the money's not there, the time's not there, the staff's not there to do that.
Mm-hmm.
But when we're thinking about then preventing these sort of further injuries, one of the sort of approaches that we sort of get that's sort of coming to the forefront now is sort of getting them ready back for their sport, and sort of going, okay, if we're focusing on returning them and figuring out what are the demands of their sport. So let's say soccer, right? Because it's or football, or from wherever you're from, but there has been quite a popular topic at the moment. You can look at the demands of the sport and go, this is what that person needs to be able to do. So we don't have a strength measurement. We don't say if we get this or that, but that's kind of actually what you're sort of talking about as well. Not always the focus. Someone could be strong, but that's not going to be the single thing that helps them.
Mm-hmm.
If we're taking that sort of approach where we just go, okay, this is the game that they're going to play, this is their position, this is how they're going to, this is what they need to do, and we sort of then have this focus of, well, both kind of in a way, rehabilitation and injury prevention kind of then overlap quite a fair bit. We focus just on their readiness, and then we're consistently sort of testing them each step of the way, where we're building them up and going, okay, here we are, here's the task that we're going to do, they can accomplish that, okay, next step, they can accomplish that next step, and then slowly rebuild and monitor them throughout that process. That seems to be the most the best way. And then looking at, when we're sending them back, looking for those niggles and looking for those sort of then small sort of points where they might be subclinical before the injury occurs, and then taking them back, building them up again. That seems like the most logical way to go about it.
Yeah, no, I think that's a phenomenal approach. And I think it's like very patient centered or athlete centered, right? Because we're focusing on performance, and luckily, somehow, miraculously, most of the things that help, if you focus on performance, most of the things that you do are going to be the things that help from a rehab standpoint, right? And that's the same with injury prevention from the beginning. If this injury prevention program isn't just going to prevent injuries, it's going to enhance their performance. So that's where you should probably focus on, and if you're trying to sell it to somebody, is more from the performance enhancement side, because people aren't worried about an injury if it hasn't happened yet. But you can say this program is going to boost your performance, and it will also help with your injury, by the way, even though I know you don't care about that. But yeah, focusing on and I think that's what you just described is where oftentimes rehab falls short, because yeah, like I'm pretty familiar with ACL rehab, or late stage ACL rehab, where we have a bunch of tests. We have them hop on one leg. We have them kick into our hand. Well, that's the worst. But we measure their isometric strength, and we say, well, they've reached the thresholds that we want them, from a strength standpoint, and from a power standpoint, and from a range of motion standpoint, and hopefully from a psychological readiness standpoint as well, as we talked about. And then we say, well, they must be good to go. But like where we're missing is, well, how to have. I think most clinicians probably don't have the expertise, and they can't necessarily have the expertise in all the sports. But it's like that's where the communication and collaboration have to happen with the people who do have the expertise in the sports, to say, okay, I've gotten them to where I can get them based on my knowledge of rehab and the sport, but I'm admittedly not an expert in the sport, the soccer, the football, the whatever. So now I need to understand from you, like, well, actually, this should happen way before. The conversation should happen. I'm not an expert. What are their demands? And how can we work on that in rehab? And then as rehab is winding down and return to sport is ramping up, how can we make sure that we've prepared them adequately, and that they're continuing to get the right guidance in that very late stage where they're close to returning to sport, and the training is very specific. And I think that's a lot of times where there's a big gap of, yeah, they look good on our end, our strength and power measures, therefore they must be ready to go back to practice. And it's like, well, wait a second, do we really understand what the demands of practice are, and what their sporting what their, like even you said, position specific demands? Like, have we really checked all of those boxes? And I think most of the time we haven't, and that's probably because of the lack of know-how, coupled with not going the extra mile of having that collaboration with the sport people who do have that expertise.
It sort of seems like, almost in a way, it really feels like a little bit of a cheat in a way, where you could sort of be like, well, if I'm just focusing on getting them to be the most, the strongest, the fastest, the most, highest performing athlete, if I'm focusing on that within obviously their constraint, like if we're thinking about people that are, they're weekend warriors, or they're masters athletes, or there's people with other life demands. But if we're thinking about how do we get them the most prepared for their support, the highest performing, it sort of seems like that if we have that outcome, then we're naturally going to get some injury prevention, and that also makes a lot of sense. But then it also kind of then drives us to understand that person in front of us a whole lot more, where we've got to understand how they're recovering, we've got to understand when they're out on the field how they're moving. And it also sort of seems like that's sort of the point where we can't say you're going to be back on the field in 18 weeks. We can't say, there's a set program, or there's a set things that you're going to do. There's potentially maybe for smaller injuries and natural history, like you do a grade 1 ankle sprain, we'll probably know that you're not going to be out long enough that there's going to be a huge amount of deconditioning. There probably is a smaller program that you can do, but with larger injuries, it's going to sound like we do need to be very much more involved potentially than we are, and where those mono interventions of here's one or here's this other won't do much by themselves, or we are doing them and then just hoping the athlete or the person just kind of does the rest themselves by luck.
Right, and that's where I think a lot of this, especially in ACL in the US, like the current paradigm for care is really atrocious, because they get discharged from physical therapy like 4 to 6 months after the injury or after surgery, and then the best evidence says they shouldn't be returning for until 9 to 11 months. It's like, well, what the heck are they doing between those time points? And it might be nothing, and it's just like the challenges of our insurance system. But it's like, well, the PT gives them a home exercise program and says, hey, keep doing these exercises, and maybe they do and maybe they don't, but those exercises really need to be progressed and supervised over time, and that's just not something that happens. And I imagine that that's the case not just in the US and not just with ACL injuries, but with a lot of injuries. And another thing a point that you mentioned is, maybe they're a weekend warrior and there's not some coach that you can get in touch with. Maybe the person is the best source of information on what the demands are, and they're this rich resource of information that maybe is not tapped well enough to understand what their demands are and what they want to be able to do and need to be able to do, and then watching them do it.
Well, like leaving the clinical room in a way, going out, finding a patch of grass.
Yeah, absolutely. I mean, that's another logistical challenge, right? You're operating in a crowded clinic with not much space. You don't necessarily even have an open space or turf, or it's too cold outside or what. But if you never watch them and you just assume that they're going to be able to, oh yeah, like they passed my return to sport tests, therefore they must be able to run and cut and juke and dodge, but I've never actually seen them do that or gradually built that up. That's a big leap of faith. But I'm sure it's getting taken very often, because it's just the environment's not set up to be conducive to looking at those things.
Well, I guess it depends again on the level of competition. Like if you're sending someone out, they've passed your test, they're sort of going and they're having a bit of a kick, and they're slowly building up over a period of time, depending on the level. Like if we're talking very sort of casual, I can see that being fine. And especially when people don't want to, if it's something that is quite casual, they don't want to put in that effort.
Yeah. As long as they understand, hey, when you go to play for the first time, 25%, whatever that means. I don't know what that means, but 25% of the time, 25% of the speed, 25% of the whatever, and that you have to be in agreement that that's what's going to happen, and help them figure out what those numbers are and like how to gradually progress that over time to get back to 100%. But do those conversations happen? I don't know. Probably not.
Well, I think that's a good sort of point. We talked about tactical, or you mentioned the word tactical before, decision making, and that kind of sort of fits there quite nicely, because it's helping people decide what to do, when and how, and providing them with a heap of sort of education. And I guess that sort of fits quite nicely in that point where tactical decision making really for them is just sort of helping them understand their body, understand pacing, understand what's happening at a very low level, which is just don't go hell for leather, purposely keep yourself low. You're going to put yourself then gradually over time, as you increase that, playing more and more of that sport, you will gradually put yourself in these more challenging positions. Your body will adapt. I mean, that's pretty much what everyone does when they're playing sport from a very young age. You go out, you kick the ball, you get a little bit better, you get a little bit better, and as you get older, the challenges get higher. I guess when we think about, then more advanced athletes, we're thinking about the exact same thing, but we're thinking more about the decision making. Do you make those tackles? When do you make those tackles? Do you feel, when are you ready to put yourself in a position where you're going to need to sprint the hardest you possibly can I think if we look at, again, World Cup, super topical, not to date the podcast too much, but we've got, our star, Matilda Sam Kerr, with a calf injury. And one of the things that we see, on the pitch is people sort of going, is she running as hard? Is she able to push herself as much? Or is she playing a much more different game tactically, because she knows that there might be, we don't want to absolutely go and with the time frame test her calf, or want to hold back and only use it if it's and potentially re-injure if it's going to be something that is going to be incredibly important to the game. So there's like two extremes there, but something to think, something to take away for both the most basic and the most advanced athlete.
Yeah, and what a ridiculously challenging position to put an athlete in, where they, especially someone who's never dealt with an injury before, but even still, these are split-second decisions that are typically made without thinking. Now you're asking the person to, before you make the right play from a winning standpoint, you have to protect that calf. And that could mess with your performance, right? And maybe if you've been injured before, you have a little bit more experience with that. But these split-second decisions, especially where it's it could, in some cases, I think that's what can contribute to re-injury if the person is over analyzing. If they're a little bit worried that if they take a wrong step, the thing's going to go pop again. So they're hyper vigilant about their way that they're moving or thinking twice, and that doesn't produce as authentic movement as it would have before the injury, and that just makes it worse. So that's a tough. It's just a tough challenge to work with, and I think that kind of gets into the trying to incorporate a cognitive load into the rehab. Have you seen any of the work with Dusty Groom's ACL, neuromuscular stuff? Basically the idea that as you're doing your return to sport training, your rehab, as well as your testing, incorporating some decision making or some dual tasking, count backwards from 100 by 7 while you're doing this exercise, or even they put virtual reality headsets on people, just trying to get the brain working a little bit more challenged than it is if you're just saying do this set of leg extensions. So because in the sport, the demands are going to be, there's going to be 8 people flying at you, and you're going to have to make the right tactical decision while you are making sure that you're planting your foot well, or whatever it is. So trying to increase the cognitive demand on the person in rehab to simulate that to an extent, in a more controlled setting, of course. But maybe that is part of the missing piece of why we see such high re-injury rates.
It's interesting because I haven't seen those papers, but I have seen the Tabiner papers. They talk about chaos.
Sure.
Yeah, where it's exactly the same sort of concept, where it's early injuries, we reduce chaos of the environment, the risk of, a lot of that's to do with people running around on a training environment that could tackle you, that could do quite, put you in positions where you have to make those split-second decisions, or you could put yourself in a very compromised position that you're not prepared for. So you take it all back, you take out all the chaos, you stick them in a blank room, no one else around, in a gym with a physiotherapist or a podiatrist,
right.
or
and
someone.
Then you do your hopping and your kicking tests, and you're sure, you're good to go. And it's well, wait a second, you might be strong and powerful, but you're 9 months since you were in that chaotic environment. So there's a huge disconnect. Maybe we have done our 90-degree cuts and our speed and agility, but we still haven't done it with an opponent or in reaction to some sort of visual stimulus, like the chaos that you're going to experience out on the pitch. So it has to be more gradual, and but it's like pretty complicated. There's a lot, like where are you gonna, you're not learning that in podiatry school, right?
Well, yeah. Yeah, we've in our undergrad we're barely covering the basics of strength and conditioning. So
right, and our physiotherapy, physical therapy schools touch on it just a little bit, like strength and conditioning, let alone that very sport. Well, and that's, I've talked to you before about how you marry your strength and conditioning with the podiatry, but that's like a very rare skill set, right?
Well, it's thankfully becoming less rare. Where then in the way we're getting there, it's it's very interesting because we sort of talked around really one thing as well, which is, and we sort of mentioned it quite a bit, but that psychological readiness as a huge component, because part of it is getting them back out in the field and confident being back out in the field. Part of it's going to be having done all of this that makes them feel prepared and ready to go. And exactly sort of what you're highlighting as well is that when we see people that are hyper vigilant, they're probably going to have a less varied movement pattern, and it's kind of counterintuitive, especially in podiatry, where we think about controlling movement, where we're actually seeing there's a huge amount of variety in movement when you run. And actually the irony is that when we reduce variability, we have more problems, and that's that hypervigilance and control. We've got some things here, which is, increasing cognitive demands, with training. We've got the chaos component as well of slowly adding more and more things to their trainings, more sort of elements, unpredictable elements, putting them in the environment that they'll be training in as well. So like often, I'll get people to go and they will do their exercises and their movements with the team. I've got one person at the moment who's going and watching and actually doing a whole bunch of running and sprinting drills next to their team on the Wednesday night.
That's fabulous.
And they're a weekend warrior, but it's like, no, you're going to get out with the team and you're going to be there and you're going to watch them. And
that's such a huge component to helping with the psychological recovery, I think, is not isolating, like keep maintaining that social support.
Is there anything else? I mean, you've already then mentioned one sort of thing, names it quite well, which is the social support. Is there anything else that we think about psychological readiness and getting someone back that's going to prevent that injury from reoccurring, that would be important?
It's a hugely under explored area, I think, there's a lot of research on it, and I think that people are not aware of it, right? So it's like we spend so much time thinking about the biomechanics and the training load that like we forget that there's this whole person, and their cognitive appraisal is like the last step in whether the injury happens or not, right? So like all of these factors, there's this situation, and then they have to make the decision whether to tackle or whether to move in this or that way. And if they're stressed, or if there's a million things that could be going on that could potentially make it a riskier situation. So addressing the psychological readiness in addition to the physical readiness is a huge piece that I perceive is very lacking in clinical practice. And there are great short surveys that you can give people. One of them is called the ACL RSI. They've adapted it for shoulders. You could probably adapt it for any body part. Just change the body part in the wording. And it's just asking people like, how confident are you? How worried are you of re-injuring again? Are you having to think about, or do you feel like you have to think about your knee, your shoulder as you're participating? Like, you want to see that the person, okay, if they're passing my tests, which we already mentioned the tests are no good, but if they're passing my tests, where is their psychology relative to that? Are they overconfident for where they're at? Are they underconfident for where they're at? If there is a mismatch, what can we do about that? Maybe that means we're referring them to a sports psychologist. Maybe that means that we just have to talk to them about what's coming up for them. Or maybe there are interventions that we can do, right? Like imagery or just guided relaxation. It's challenging because most of us are not trained psychologists, right? And we shouldn't pretend to be. But there are so many things that we can do, whether it's just the communication aspect or the measurement aspect, or some of the interventions that we can do that are low skill, or maybe it's like, no, this is outside of our scope and we need to make sure that we're referring them to somebody who has more qualification to tackle that.
I guess one of the things I think about from like when we look at like outside of the sports literature into like the pain literature at people when they're dealing with these kinds of issues, it's looking at more going, giving them positive experiences with tasks. And one of the things from what you're explaining, what we're potentially overlooking is when we're doing exercises and movements, we're contributing to their confidence. When we're getting them out and we're getting them running and we're getting them moving and we're giving them tasks, we're constantly giving them new bits of information about how their body works, and they can start to build that confidence, and we slowly like increase that challenge. And potentially
so that's something easy that you can reinforce, right? Like, hey, look at how well you did this, that they might not have noticed or observed, that can then help them increase that confidence.
And that can be done like throughout the rehab process and
yeah. Don't wait until the end to be like, yeah, you look good, you passed my test. Like, no, that's those confidence boosters, those helping people violate their expectations of what they're able to do. That happens from the beginning.
So one of the things, sort of to end on, one of the things we haven't talked about really at all is shoes and orthotics and where they fit. And I guess one of the things that we're seeing here is that, well, there isn't really like a point where we're going to see probably a huge primary intervention, like changing someone's shoes.
That was when you posed that, this was going to be something that we were going to talk about. I thought, I don't really see it as a primary prevention strategy. Like, you would have to be able to provide evidence that if you give this orthotic or this type of footwear to everybody, it's going to reduce, you have a control group and you have an intervention group. The control group, you give a sham or nothing. I don't know how you give them a sham orthotic. Maybe you can. And then you give the intervention group the orthotic that you think prevents injuries. Like, show me the study that is going to have a really meaningful effect. And you mentioned that actually there maybe is one in a military population where that seems to be effective. Like, that shocks me. And maybe it's true. I'd have to read the study. But on the whole, I don't see that being a helpful strategy. So then the next line of thinking is, well, maybe we can identify the people who need the orthotic, right? Well, let's look at their posture. Let's look at their running mechanics. Let's look at their flexibility or strength and say, well, they have this deficit or these deficits, therefore this type of orthotic is going to be a good match for them. That also guarantee isn't going to work. Because
we don't even have those risk factors. We don't even look for biomechanics, and then we don't even know if orthotics are actually going to address those biomechanics, even if they were a risk factor. We don't have that.
Right. But that's what people do, right? They say, I can look at you and I can look at the way that you stand or the way that you run, and I can recommend this is the orthotic for you, and this is going to be what's helpful. That's so many steps removed from anything that we have from an assessment or screening standpoint and intervention standpoint, to be able to say, we can identify this risk factor, then we can give them the intervention, and that's going to work better than giving them a different intervention or giving the intervention to the people who don't have the risk factor. Like, none of that, just from the like, we're applying it to the specific argument of orthotics or specific footwear for, that a podiatrist could prescribe. But like, this is blanket true across all risk factors, like you just can't identify people with the risk factor and then intervene on them in a way that's better than just giving the intervention to everybody. But then again, like if we take exercise as the intervention, well, we know exercise as the intervention is actually pretty good with injury prevention. We can just give that to everybody. We don't have that data for orthotics.
Well, the other thing is the numbers needed to treat are quite high. There's a cost involved. There's a number of things there.
Yeah, so exercise is great because it's low cost. You can probably get it done in a short period of time with minimal equipment. But when you start talking about, well, we need to screen, that's expensive. We need to make these orthotics, maybe that's expensive. So it's not, there are drawbacks to this as well. And maybe like exercise, we know there's no negative side effects besides soreness. And maybe that is a negative side effect because, like you said, if you do the Nordics and you fatigue the person and then they go have to train or compete, that you have to think about that. But like, we don't know. Maybe you give them the orthotic and it actually makes them worse. or at the very least, you give them a different footwear. You take them from a maximalist to a minimalist shoe or vice versa. And it just redistributes the forces, right? It's still the same forces, but now instead of this pattern of injuries, they have that pattern of injuries.
And that sort of really kind of speaks to really exactly where we're sort of thinking, where it's like these kinds of interventions might be more secondary and tertiary based interventions, because you've exactly said, rather than changing, rather than removing force or taking away something, we're changing it, and we're identifying people that are coming in and saying, well, actually, you might benefit from this.
Right, that's the perfect application for it, right? So when you're talking about primary prevention, you're saying, well, we're going to try to predict who we think is going to get injured, and we can't. But in the case of secondary and tertiary prevention, we already know who's hurting. Those are the perfect people where, again, we're not saying, hey, you have to wear this orthotic forever, or hey, you have to switch to this opposite footwear forever. We're just saying right now, this hurts. We know that this hurts because you're telling us this hurts. What can we do as a short to medium term modification while we're throwing the kitchen sink at you in all of these other ways? What can we modify from the environment standpoint? Shoe wear, orthotic, training surface, and then we can do that in the short term, see how that feels. There's immediate feedback there, right? And maybe it's a full-time change, or maybe it's just an introduction of the orthotic or the different shoe wear for part of the time that you're training, whatever. And at the same time, we're monitoring your training load. We're looking at your sleep. We're looking at your nutrition. We're looking at your hydration. We're looking at your recovery strategies. We're getting you stronger. Taking that, like, we're making sure that you have a good warm-up before you go out and engage in the sport. So it's like this huge picture thing where the orthotic or footwear is one piece of it. Who's to say what amount of contribution that's making? But there's certainly a psychological component, and there's an immediate, well, that my pain is less, right, with the introduction of this thing, or the removal of this thing if they came to you already with something that you don't think is the right thing for them, or you take it away and it feels better. So that's where I see, hey, there's a place for this for sure, because it can immediately modify symptoms in the way that few things can, right? Besides just removing the training load. Like, sure, well, if they rest, they get better, but then that's not a permanent solution. So that's where I do see the applicability.
Yeah, and I think that makes a lot of sense, and I think that sort of clears up as well where we sort of get confused, because you look at I see, quite a few people kind of go, well, I know they prevent injuries, or I've seen it happen, or more of that anecdotal side of things, because it does immediately help, and someone kind of keeps getting injured and then they get an orthotic and all of a sudden they're not getting injured anymore. And we can sort of see that, where that sits, because most of our research is primary intervention.
Yeah. But then, I wonder with that too, well, what else did they change? Like, how well controlled was this? Did they really do all of the same mileage, and then the only thing that they changed was the shoe wear or the orthotic, or they changed the orthotic and they also were more mindful of their training load?
Because they're spending money.
Right. And they're more like, they want to make sure that this works. So their belief systems have changed. They trust the practitioner who prescribed the orthotic, and that has improved their confidence in their body. They feel more powerful with the orthotic, or more injury proof, for lack of a better word. And maybe that could work for or against them, right? Because now maybe they think, well, I can do anything now. I can run 100 miles a week because I have this orthotic that's going to bulletproof me. Or maybe it gives them the confidence that they were missing, and it's a positive factor. But again, like when the clinician is saying, I give this orthotic to all my patients and it works, and my patients don't get injured, it's like, but that's not yes, that's your anecdotal evidence, but it's biased it's clouded by your observation of the situation, as well as the so many confounding variables that are going on with these patients and their interaction with you.
Yeah, I don't always see that as a particularly negative thing, though. Like, I mean, with anything, like you give anyone an intervention, you can't, and this is kind of the problem I see we run into research, we can't separate it from everything else. I mean, we see people with knee pain get a surgery that's no better than placebo, but they get better after the surgery because they now have the confidence and the movement to move. And so I don't always see that we need to separate it out. I guess I see the issue as telling someone that's what did it.
That is it. I agree with that 100%. It's like tracing it back to the introduction of this intervention is what fixed your pain, when it's this constellation of factors. Like, we should just be more cognizant that it is this constellation of factors, and that's okay. Like, let's take advantage of that, right? Let's take advantage of this person realized that they needed some help. They came to me. I am in a position where I can help them. Maybe I can introduce this orthotic, but maybe I can be more careful in the narrative that I'm describing it in. Maybe, right? I don't know. Maybe.
Or maybe the orthotic is the thing maybe the orthotic is the thing that we start with, and we say, well, it's very clear that you would benefit from this. It's very clear that we'll be able to do more. Why don't we start here, and then, over time we can start to sort of talk more. But, there are definitely patients where we go, it seems like this is such a smart thing to do. And then we don't have to have the entire plan from the get-go locked and loaded, and we go, this is what's going to happen along every step of the way. But I think, especially in podiatry, that's kind of what we're kind of trained to do, where you identify the bad thing, you fix it, or you identify the problem and you have a really long plan. I guess we're sort of now moving to a model where we are much more thinking about the individual, much more thinking about that person and how we're helping them over time.
Yeah. And I think that's like, yeah, of course you want to have a plan, like lay out the plan, but then be flexible, right? And I, like what you just described of, well, we're going to introduce the orthotic. That's a quick way that we can modify the symptoms to get you back to doing the thing in whatever amount that is appropriate. And then simultaneously we can add some of these other things so that maybe we don't need the orthotic forever. Like, I don't know. Like, what's your, when you're prescribing these things, do you present it as a permanent fix, or do you present it as like it's funny. It's funny even saying that words out of my mouth, because it's like, well, clearly it's not a permanent fix. Or do you present it as like, here's something that we're going to try in the short term, see how it feels while we're working on some other things?
Yeah, it's absolutely, I think, always a temporary. I would always approach it as a temporary sort of point for pretty much most people. I say always and then most. But yeah, most people will have it will be more of a temporary thing, and then seeing what they need longer term and seeing what happens naturally, whether we need that, because we are changing forces, we're not removing them. And so we are sort of seeing how they then respond. And even if they do respond, some people, we issue an orthotic and it doesn't get the result that we want, and we go, bummer. But that's, and sometimes, if as long as we go in with the right narrative, we explain the pros and the cons, we explain the risks, some people are quite happy to go, well, I'm glad that we covered that. and that we're not, and we don't need to worry about that anymore. I know how to focus more on over here. But yeah, it is always, I always approach it as sort of a temporary measure first, and then certain individuals where they've had motor vehicle accidents, significant changes in their foot posture, things that you know are going to be much more permanent. Are much more changeable, but it's generally not sort of the people that we're thinking about when we're talking about the wider research. But yeah, absolutely, it's something. But I also don't focus on making a change, everything all at once. And I think that's kind of the narrative, the orthotic, the exercises, this. It's trying to almost like, if you've got an individual who's coming in who's sore, who needs something from you, it's almost like it's what do they need now, and then developing that rapport.
Right.
And then what are we going to do in the future?
I think that's tricky. That requires an understanding of the literature, and you're marrying that with your clinical expertise to say, if I tell you to change, well, for two reasons, you probably shouldn't change everything all at once, because then we won't really know what effect anything had, and it would be overwhelming, right? But how do we figure out which are the orthotic is a quick thing that we can try right off the bat. But then what's like the next lowest hanging fruit? And I think that you get that from your conversation with them, as well as your assessment, and to say, oh man, like this thing is really atypical from what I've seen before, very different between sides. Maybe that's something that I've seen that we can make quick changes in. Like maybe you start there.
Thank you very much, Travis, for coming on. I think it's a perfect sort of point to start, because I think we've really kind of nailed it down. It's from our chat, it's been identifying that we're no longer looking at a single cause and a single thing that we're preventing. It's sort of we're shifting from moving to the individual, and I think sort of ending on that point where we're narrowing it down, that while we don't have the research, we can still look at that individual and figure out what's going to be the best to get them moving, working, getting them back to a high performance, in their sport, and whatever high performance looks like is sort of a fantastic way that we can sort of encapsulate what we're doing when we're thinking about preventing injury.
And I think too, it's marrying that understanding of the research with the person in front of you, right? So I know from the research that these are the biggest risk factors for an injury or a re-injury, and then how does the person look in front of me? And I can kind of say, well, they look really funky in this way. And then I know that this works in general, or this is a risk factor. So even though they look pretty good on this, like I know training load is a big deal. So I'm going to make sure that I'm addressing that with them, along with this thing that maybe doesn't show up in the research all the time, but like that looks pretty funky to me.
Yeah, and I think that's just where I think we're going to end up with a lot of, talking to a lot of people, is we're going to go very in depth on certain things. Then we're going to come back to pretty much look at the individual, treat the individual, figure out what's working best for them, and then go from there. And I think I think we've just covered a lot of ground to sort of give people the ability to think about that and talk about that a little bit more.
Yeah, and you're just, for me as a scientist, my starting point is what I can glean from the research, and that's what I take in, or what I would take into the encounter, as opposed to just like, I don't know, if you don't know the research, then you're just pulling things out of thin air.
Yeah. So if people want to find you and learn a bit more about you, your work, watch your masterclass, where can people find this all?
I guess my website, travispollen.com, is a good place to go. You can contact me there. I'm also, I'm not that active on Instagram. I am in my DMs, but I don't post as much as I would like to. But Instagram would be a good place to find me as well. My handle is fitness_pollinator.
Perfect. Well, again, thank you again for coming on and having a chat.
Thanks, Alex. I always appreciate chatting to you. It's enlightening in so many ways.
Perfect. Well, thank you everyone for joining us. This has been the Rehab Podiatrist podcast. Do you have any questions for Travis? You can find him, like he said, on his website. You can send him an email. You can go to his Instagram. If you have any questions for me, you can find me, the Rehab Podiatrist, on Facebook, Twitter, Instagram as well, or my website, the rehabpodiatrist.com. And we'll see you guys all in the next episode.